This is my presentation for the San Antonio Society of Pathology. I'm just going to share this as well. This is my senior resident presentation for the San Antonio Society of Pathology. I have no disclaimers, and learning objective is identifying a working diagnosis of thyroid cystic lesions. I think this is a good senior topic because as a second year, I had a similar lesion before, and I made a mistake. I called it benign, and ultimately it wasn't. So I think this is a good full circle because this time around, I did not call it benign. The clinical history is a 21-year-old healthy male with no previous medical history with a 2-month history of a right large level 4 neck mass. CT neck with contrast was done and showed a right thyroid nodule measuring 1.2 centimeters with inferior calcification measuring 9 millimeters and a right supraclavicular cystic lesion measuring 5.2 by 2.9 by 6.7 centimeters. So here's a coronal view of this supraclavicular enlarged cystic mass, and here's the sagittal view. This is the axial view of the right thyroid nodule measuring 12.2 millimeters, and just inferior to that, you can see that mentioned 8.5 millimeter calcified nodule. I was at adequacy, and 2 FNA passes were done on site of the supraclavicular lesion. And I remember seeing it was scantly mildly cellular. You can appreciate this cystic degeneration with a lot of macrophages. But as we look closer, we can see that these cells were bubbly and vacuolated, kind of maybe suggesting like cyst lining cells. However, these cells were pretty enlarged compared to your adjacent neutrophils, at least 1.5 to 2 times as large. This view really suggested how these cells look like cyst lining cells. They got this strung out appearance. The nuclei are elongated. However, these cells were unusually large compared to your red blood cell. And here demonstrating the cyst lining cells, or they look like cyst lining cells. This view, we appreciated how it looked kind of hobnailing, as you can see here, with this like comet tail appearance. This is the pap stain to better visualize nuclear detail. We didn't see really papillary structures, which we were thinking of because he has a thyroid lesion. Could this be a met? So we looked for inkies as well and nuclear grooves, but we didn't see them here, which we thought were a little bit unusual. Maybe this could be just understained right here because it was too thick, but this could suggest like a papillary lesion. So this is the cell block the next day, and as you can see, it's very scantily cellular. But as we look here, you can see that kind of hobnailing look. You can see the vacuolization that we saw on the diff quick, and here's the hobnailing look in comparison. Here you can see the suggestion of a fibrovascular core. So your differential diagnosis was a metastatic clear cell renal cell carcinoma. Usually presents in sheets. PAX8 is not helpful because that will stain your thyroid lesions. So a TTF1 and thyroglobulin can be helpful in distinguishing these two entities. Metastatic PTC, the hobnail variant of PTC, where greater than 30% of tumor cells would have these hobnail features. It has aggressive behavior, high incidence of infiltrative tumors and metastatic disease, usually highly cellular and distinct micropapillary configuration. Cystic PTC is an unusual presentation seen in less than 10% of cases. Cystic squamous cell carcinoma, branchial cleft cyst, which is in the lateral portion of the neck. It's a congenital lesion due to incomplete obliteration of the branchial cleft, and often stratified squamous epithelium surrounded by lymphoid tissue, often with follicles, and a thyroglossal duct cyst, which is a developmental anomaly of the thyroid gland. It's the number 1 common congenital anomaly. Midline location, the number 1 congenital anomaly of the neck in childhood. And it's based on location. You can have the respiratory type epithelium if it's further down, or squamous epithelium, often surrounded by thyroid follicles if it's further up. So metastatic clear cell renal cell carcinoma. So here we can see thyroid follicles and these sheets of clear cells and packeted architecture with a lot of vasculature. And here's a PAP of a clear cell renal cell carcinoma. You can see kind of the foamy cytoplasm. You can see mainly central nuclei with pinpoint nucleoli. And here's another view. And as you can see, these are also larger than these degenerated red blood cells, so somewhat similar to what we saw before. This is a hobnail variant of PTC. You can see kind of these comet-like cytology here. And you can appreciate that a lot of them are micropapillary configuration. You don't see a telltale fibrovascular core. And they can have these secretions as well. And here's the cytology showing you that distinctive comet tail-like look seen in hobnail variant of PTC. Cystic squamous cell carcinoma. So here is an image of a patient with cystic squamous cell carcinoma, kind of similar looking to the one we saw in our patient. And here you see kind of cystic degeneration, something like what we saw in our passes. You do see these very condensed cytoplasm with these hyperchromatic nuclei, as you can see here. And you see a lot of necrotic debris with degenerative cells with atypia here, with this very enlarged nuclei that's very hyperchromatic. So these can be tricky to identify. Here's an H&E of a metastatic squamous cell, cystic squamous cell in a lymph node, where you can see the lymphoid tissue, and you can see the endophytic growth of this squamous cell carcinoma. There's loss of polarity as you look closer, and some nuclear atypia with this multinucleated clumping. And it can have sometimes a papillary-like growth, as we can see here. This is to demonstrate how some areas you can have atypia, but very tricky cases, they can look like branchial cleft cysts, where there's not as much atypia, there's no mites above the basal layer. Here's the branchial cleft cyst. You can appreciate the laterality of this. It's not midline. You can see lymphoid follicles, and it's lined by, it's hard to see here, but squamous epithelium. And just to show you how tricky this is actually a case of metastatic papillary thyroid carcinoma to the lateral cervical lymph node, mimicking a branchial cleft cyst. You have these lymphocytes, but actually, if you look closely, look how enlarged this nuclei is compared to these lymphocytes. You can fit 4 of them in here. Thyroglossal duct cyst, you can see the midline structure here. And as we look closer, we can see kind of, as in this case, respiratory type epithelium. And you see these thyroid glands underneath. So the diagnosis, well, we got a thyroglobulin, PAX8, and TTF1. They were all positive for the cells of interest. And a thyroidectomy was done a couple weeks ago, actually a week ago. And you can see the image correlation. We had that calcified nodule. You see the calcification here, and these lesional cells. And so this was consistent with metastatic PTC. I'm just illustrating how tricky these can be, though, because they don't have any inkies, they don't have any nuclear grooves, they are enlarged. Here's a picture of an adjacent thyroid, normal thyroid follicle, and how large these neoplastic thyroid cells are compared to these ones. The cells are vesicular, they're enlarged, they have pinpoint nucleoli, but again, no inkies or nuclear grooves. Here's the corresponding histosection of the supraclavicular cystic mass. And you can see, I demonstrate this field of view to show you, if you sample just this area here, you might get non-diagnostic. So it's very important. It's very important that sampling is done on the solid regions as well. and to get that the metastatic PTC portion. Here is the H&E correlate of this kind of vacuolated feature that we saw in our DiffQuick. And here I demonstrate how tricky these can be, because these cells are undergoing cystic degeneration, but they're neoplastic cells too. And that's why these neoplastic cells have this kind of cyst degeneration, a cyst lining look, that strung out appearance. So discussion, metastatic PTC to the cervical lymph node occurs in 5 to 10% of patients. It may represent the first clinical manifestation in 20% of patients. Atypical histiocytoid cells are the predominant cytologic findings in approximately 13% of metastatic PTCs. What that means is they have a histiocytic or epithelioid appearance, abundant cytoplasm, hypervacuolated cytoplasm as well. You might not have inkies. You may not have nuclear grooves. And knowing that cystic PTC might not have the classic features of PTC is helpful to avoid false negatives. These atypical you don't want to call this a cyst or a branchial cleft cyst, and this patient actually has metastatic PTC. These atypical histiocytoid cells are thought to be associated with cystic change from contact with cyst fluid and represent neoplastic cells undergoing degenerative change in form of vacuolization and repair-like appearance, as you can see here. For a lateral cystic mass over 40 years of age, a differential of squamous cell carcinoma should be considered in addition to branchial cleft cyst, and thyroid papillary carcinoma should be considered in younger age groups. Like in our patient was 23, healthy, no other issues. Thank you. And here are my references.